Good afternoon, everybody. Thank you, Debashish, for giving me this opportunity to come here and share my few ideas about this interesting topic. And I must acknowledge that this is a very rare privilege for me to speak before both of my mentors, Dr. Cherian and Dr. Iyer. Not very often I find them together in the audience. So it's a very diverse group of lesions, the conotruncal abnormalities. These are the lesions which are characterized by developmental defect in the conal septum. They are anatomically and surgically very diverse. They've got a extreme variability in the development of subarterial coni. What we are going to discuss here is the set of lesions which are feasible for biventricular repair. So biventricular repair is definitely not possible if there is a evidence of ventricular hypoplasia or severe AV valve pathology or where ventricle septation is not possible. So the basic surgical aim in this group is to fix the outflow tracts. Biventricular repair involves essentially two steps. Fix the LV outflow either by using an intracardiac tunnel, connecting the left atrium to the outflows, usually the aorta, via the VSD. The tunnel is expected to be short, straight, and wide, or do an arterial switch operation or aortic root translocation if the anatomy is not feasible for an intracardiac tunnel. The right ventricular outflow tract is usually dealt with establishing an RV2PA continuity, either using an intracardiac channel or an extracardiac channel, or pulmonary root translocation if the native pulmonary valve is suitable for utilizing it for function. So what basically gives rise, what is a substrate for giving rise to these residual issues? The first and foremost is LVOT reconstruction. And first, we should look at the size of the VSD. If the VSD is large, then evaluate the subaortic conus. If it is small, it becomes a straightforward tetralogy type of a DORV or contruncal abnormality repair. If the subaortic conus is prominent, then we'll have to go ahead with the subconal resection. If the VSD is restrictive, these are the patients who, if they have a prominent conal septum, we can liberally resect that conal septum. If a conal septum is absent, then we have to enlarge the VSD still by going ahead with the anterior septal resection. Similarly, the substrate for residual problems in the RVOT, again, how we construct the RVOT. We have to calculate the tricuspid pulmonary valve distance. If it is greater than the aortic valve, it is easy, straightforward total intravascular 10. But if it is less than the aortic valve, and if the tunneling is not possible, and if there is no PS, then we can straight away go with the arterial switch operation. If there is a PS, then we have got a whole gamut of options available in the surgical armamentarium. Additional surgical considerations which come into picture when we deal with this problem is abnormal insertion of AV valves on the conal septum. The tricuspid attachment is very important here because it can come in the way of adequate resection or intracardiac tunnels. Mitral valve attachments usually are not that uncommon. Abnormalities are not that uncommon. If it is associated, it's associated with independent mitral valve pathology where it needs a very complex biventricular repair or maybe a univentricular approach. Ventricular septation without a loss of ventricular volume on a residuant shunt is very essential here. And a valve mechanism in the RVOT is very important if we are looking at the long-term survival of these patients. Now, this I don't want to discuss in detail because Dr. Devananda is going to discuss this in detail in his talk here. But just want to tell you that the pulmonary and the aortic annular diameter ratio, which was discussed previously, I got this idea when Dr. Chinnaswamy Reddy presented his talk in a few years back in one of these conferences. This is a very important thing. This ratio will determine which will be your approach. The residual surgical issues here can be in the outflows, semilunar valves, residual shunts, coronary insufficiency, ventricular dysfunction, and conduction defects, of which the LVOTO has been a surgeon's nightmare every time when we operate these children. Early LVOTO is essentially technical. It is caused by malalignment of the left ventricle with the aortic long axis below the patch. It can be avoided by a proper case selection and surgical technique. Late LVOTO develops due to persistent curvilinear passage of the left ventricle output to the aorta. And this left ventricle is basically contracting against a synthetic non-growing patch. So this is a subset which gives rise to a late LVOTO in these subgroup of patients. This is a paper which has analyzed Rasteli. We are discussing conduitless repairs here, but Rasteli is the commonest thing which we perform in our setups. And we have realized that over a long period of time, almost 10% of patients need LVOT reinterventions in this patient paper from Dr. Barron in 2019. Now, outflow tract obstruction on the right side, there are a lot of anatomical substrates which give rise to problem. A small subpulmonary conus, long tubular infundibulum, pulmonary annular hypoplasia, dysplastic pulmonary ventricle, pulmonary valve, splaying of the pulmonary bifurcation of the aorta when you are doing a root translocation, stretching of the branch pulmonary arteries, inadequate patch size, technically improper conduit placement if at all we are using it. Late RVOT basically is accelerated by these factors in the late postoperative course. Now, this is a paper which was published by Lecombe's group in 2011 in JTCVS, which analyzes 25 years outcome after REV procedure, which is definitely without a conduit. Here, if you see, the only substrate, the thing which needs is redo interventions in the right ventricular outflow tract. And REV procedure here in their series, the interventions, late interventions for left ventricular outflow tract has been pretty less as compared to the right side. Aortic valve regurgitation, again, a very important factor in root translocations. Early AR is essentially technical. Moderate AR following aortic root translocation has been reported in many studies. Pulmonary regurgitation, free PR happens in all the patients who have a patch repair in the RVOT, like NEV, Nikaido, HTTS. Monocus patches have been used in literature to tackle this, but it's only for short term. It doesn't have any long-term efficiency. Rasteli and modifications of REV, aortic root translocation and half-turn truncus, which use still conduit to avoid PR. That's the best way you can avoid a definitively PR in the post-operative course with added disadvantages. Now, this paper in seminars in 2017 has compared the outcomes of Nikaido, Rasteli, REV, and double root translocation. And what we can see is Nikaido is the only group which actually has incidence of more than mild AR. Most of the other approaches have not had these aortic regurgitation problems. But interventions on RVOT have been uniformly there in all groups, obviously maximum in Rasteli and REV. But even Nikaido procedures have got reinterventions for RVOT. Residual VSD, especially intramurals. Now, this subset of VSDs are very tricky. It is a surgeon's problem always because it's very difficult to diagnose them intraoperatively. Around 11% of them have intramural VSDs. They're very common in conotruncal abnormalities. And the shunt continues to increase over time as the child grows. So it is more often seen in intraventricular repairs as compared to translocations because we use intracardiac tunnels, and it can be prevented by properly delineating the margin of the VSD and not sewing the patch onto the trabeculations, which look like the obvious margin. We have to carefully inspect, divide the trabeculae if necessary, and find the exact margin of the VSD to hopefully avoid this kind of problems. Coronary insufficiencies, they can be either technical by distortion of coronary arteries while translocating, or injury to the septal arteries after septal resection. Ventricular dysfunction can result because of coronary problems, extensive septal resection, extensive surgeries, residual problems, or late onset ventricular dysfunction essentially because of outflow tract obstructions. Conduction defects, incidents are same in Rasteli and REV as compared to normal routine intracardiac repairs. But root translocations in CCTG especially are associated with slightly higher chances of heart block because of the inconsistency of the course of the bundle in these patients. Varies from 3 to 10% in various published series. It warrants an additional surgical procedure of a pacemaker. So overall prevalence of residual surgical issues, if you see, Rasteli is mostly associated with more interventions in left and right ventricular outflow tract. REV, again, it is less commonly associated with the outflow tract interventions, but leads to pulmonary regurgitation. Nikaido, very reasonable, good outcome in terms of outflow tract obstruction, but has a chance of including aortic regurgitation. And so is this root translocations from the double root transfers of half-turn truncal switches. So to summarize, biventricular repair of complex conotruncal abnormalities have evolved significantly in the last 5 decades. These diverse pathologies demand a tailored approach. we need to choose the strategy which is the best for that patient. Both conduitless and conduit repairs have short and long-term residual issues common as well as specific to the type of the surgery. A thorough pre-op evaluation is essential to avoid some and delay the rest of these residual problems. Despite of optimal surgical techniques, there is a significant chance of re-intervention which needs to be realized, and the family needs to be informed about this. Thank you.